Hello, guys. How are you doing?
Glad you're with us.
Good morning, Lo.
Morning.
Hi. Good morning.
Hi.
And Murilo, thank you for your last slide. Please only choose 3 of those leadership principles to mention, as time will be short. Thank you.
Okay, thank you, Tom.
I think whenever you want, we may begin.
Okay. We can start now if you want.
Please go ahead.
Good morning. This is Elliot Sloan from Florida in the US, joined by Riyadh Farah as the co-moderator for this morning and afternoon session. From Lebanon, he is joining us. We have 3 speakers, Paula Berrio, Kim Greenwood, and Murilo Canto, who will be talking about their efforts and successes in cost and ROI management. Next slide, please. Next slide. So we have been doing presentations and discussing at advanced clinical engineering workshops the concept of cost and support for clinical technologies for decades. Some of my involvement goes back to early days of 2001. Next slide. We also have presented these in tiny countries like Dominica. We've had speakers and lecturers from throughout the world. Next slide. We have expanded the discussion to total cost of ownership to consider the complexities of computers and networks, which adds greatly to maintenance, security, and other costs. Next slide. We've created spreadsheets and simple analytic tools to look at the cost of inflation, deflation, cost of money, net present value of investments across many different kinds of technologies. Next slide. All of these are in the context of the total cost of ownership for clinical technologies is maybe only 1/10 of the overall cost of support and maintenance over the life cycle for all kinds of clinical technologies today, and that cost is going up. Next slide. We know our real costs are way beyond the purchasing costs as the classic tip of the iceberg. Next slide. Been writing some articles and chapters to try to address this inflating cost and the management of it. Next slide. All of this really harkens back to ECRI's first publication of Devices and Dollars in 1985, when something as simple as a spreadsheet required timeshare, or what we now call cloud computing, in order to do these calculations. Next slide. And now we have to deal with the COVID-19 coronavirus technology decisions and those long-term cost management issues. Next slide. And that includes ancient devices that we're pulling out of warehouses and stockpiles, diverse ventilators coming from many other hospitals and donors, new open source ventilators and products that are being built in individual hospitals, and new products that have EUA or emergency use authorization only, that in fact may not be used past the duration of the coronavirus pandemic. Next slide. There are many topics in the cost of effectiveness discussion. The next few slides are simply from the overall outline. We're looking at health technology broadly, what it is, the role of the clinical engineer, what he and she does in this world, and the concept of cost effectiveness and return on investment. Next slide. There are many resources that are available to all of you. All of the slides and materials that I'm presenting and everyone else here is presenting will be provided to you, and we're more than happy to provide additional information by the email addresses that you already have. Next slide. There are many principles of the clinical engineering community. All of these are broadly written about. They are not that easy to understand or conquer, and we're all in the midst of learning, and that's what this session is about. Next slide. There are so many cost impact and implications for every decision we make. It affects our current budget, it affects the overhead of the hospital, it affects the staff, the long-term maintenance, and the viability of healthcare in each of our countries. Next slide. Now we'll change to Riyadh and let him talk about some of the MENA concepts and issues. Welcome, Riyadh.
Thank you. Thank you, Elliot. Hello, everybody. I'm so pleased and honored to be co-moderator with Elliot, and very happy to present the experts in clinical engineering fields and hear their success stories and leadership in hospital, regional, and national level. They will be presenting their expertise on how clinical engineering can lead a cost-effective HTM. I personally worked in the Middle East area, in the AMRO region, also called the AMRO region, with the Arab Hospital Federation and the Middle East North Health Policy Forum, MENA HPF, and of course collaborated with the IFMBE. We have around 28 countries in the Middle East North Africa region. Definitely different countries, they have different healthcare systems, they have different plans and different economies, and therefore they have different technology levels. Some countries, they have big investment in medical devices, while some others lag a little bit behind. And this is normal, but what's essential is that all clinical engineers have common challenges in all countries, whichever is the level of investment, because we need to manage these millions of dollars of technology and we need to manage them properly. That's why we all need proper HTM, health technology management. We all need proper health technology assessment, and we need proper regulations and accreditation. Obviously, the MENA healthcare market is worth around $144 billion. It's a big healthcare sector. And in the Gulf region, which is called the GCC, they have $69 billion healthcare worth. And this is big. And that's why we need clinical engineers, very effective, very active in this area. It is good to mention that two countries, Saudi Arabia and UAE, have more than 74% of the healthcare market in the GCC. And that's why there is a big variation between one country to the other. It is worthwhile mentioning that the medical device market growth is expected to grow by 8% in the MENA region, which is much higher than any other market. And this is as per the Euromonitor. And Lebanon had the higher density per 1 million population as per WHO in 2013. Another point to mention is that the hospital beds density in the MENA region is a bit less than other countries in Europe and America. So we expect lots of hospitals to be built, and there is a big need for extra hospitals. So a final note, a take-home message, we need to work together. We need to attend IFMBE webinars and to learn and improve in clinical engineering and leadership skills, and improve awareness in clinical engineering and promote recognition. These words are very few words just to mention the importance of clinical engineering work. Next, please. Now we're gonna hear three important stories from colleagues, from experts, from Colombia to Canada to Brazil, and they're gonna share with us their expertise in cost effectiveness and their management of their medical devices and the savings they did. Paula Berrio from Colombia, she's gonna tell us her success story in the hospital, on hospital level. Kim Greenwood, working from Children's Hospital, Ontario, Canada, is going to propose and explain the cost effectiveness approach. through a regional clinical engineering service in Canada. And Murilo Conto from Brazil is going to explain his expertise with the Ministry of Health on nationwide expertise, proving the cost effectiveness and total cost of ownership of medical devices. Please, the floor is yours, Paula.
And before we begin, just to let everybody know that we will be taking your questions in the chat box. We've asked each of the speakers to speak for 15 minutes, and then we will come back and answer all the questions that we can. Paula, the floor is yours.
Hi, thank you. And good morning, everyone. I'm a clinical engineer here in Colombia. I work in Hospital Pablo Tobón Uribe, which is located in Medellin, Colombia, in Latin America. Our hospital is a private general hospital with high level of complexity. And we have about 500 beds, licensed beds, and we are accredited by national and international agencies. Next slide, please. Okay, so healthcare sector and institutions had increasing demand in high quality services, so that impact directly the expenses of the services, and simultaneously institutions are suffering economical constraints because of the high costs related to equipment, personnel, and devices, without limited monetary resources available. As clinical engineers, we have to manage the medical equipment in all of its life cycle here in the hospital. So we have to, we have an important impact on budget of our institutions, and we can add value to our profession if we adopt improvements to decrease the expenses and diminish the expenses. So the first improvement we have done is in our technology acquisition process. So we have the same initial steps, but in this process, we add the participation of IT people and occupational health people. So it led us to include in our technology demonstration and in our technical specifications review costs related to, for example, interoperability networks and costs related to safety use of the equipment. Additional to that, we add a specific step of adjustments. So we do adjustments, economical and technical adjustments based on needs and projection of our institutions. So it led us to diminish cost in our evaluation. And we are continuing using the TCO methodology, but after of that, we are reviewing many options of property, for example, purchase, rental, or different kind of property options. So we can choose all of the costs. We can have all of the costs included, and we can choose the best alternative available for us. Next slide. Other example and another input we can do as clinical engineers is the participation in the return on investment evaluation of the new services delivery opening. So it is important because it is usual that project managers just have into account just the initial cost of the equipment. But based on the iceberg theory, we know that 80% of the costs are related to hidden costs. So it is important we participate in this analysis because we can add these hidden costs, and we know it could change the entire result of the evaluation. Next slide, please. Okay. Another input we can, or another strategy we have done here in our hospital is it is important to knowledge our services. For example, NICU, ICU, and their needs. So it could lead us to propose low-cost engineering solutions for user cost of damage and to solve problems they had. So as an example, we realized that about 23% of our cost of damage was used the last year. So, and we realized that the high maintenance cost for these cause of damage was related to our flexible endoscopes. So we started a specific measure of failures in our flexible endoscope, and we proposed a process change. So that process change, since the transport and the reprocessing of the device led us to diminish about 80% of the expenses in distal and impact damages with an investment of about 11%. Next slide. Here are other examples we have implemented with low-cost engineering solutions for problems we had in Colombia. So we proposed the use of 3D printed surgical table contour protector because we had a lot of control damages for failure, for fault cost. So these 3D printed control just cost about 10% of the cost of the new control. Another measure we had is that we implement a quick guide and accessories for cleaning and disinfection of TE probe in our sterilization process because we noticed we have many damages of our TE probes related to spills and inadequate manipulations from users. And the last picture you can see is the accessories and lens for endoscope testing before cleaning and disinfection, because here we had an important problems related to leak tests and the inspections we did before the cleaning processes. Next slide. Yeah. Next. Okay. Next, the other important strategy we have done is the participation of the construction of the budget related to technology acquisition and management. So we are guaranteeing that these 5 inputs are present in the budget we construct every year because regulation is changing, so it could have many costs involved to accomplish new regulations or changes, costs related to expansion and opening of new services, technology replacement needs, technology surveillance and technology assessment processes, and changes and costs related to that, and costs related to maintenance and technology upgrades needs, including spare parts. Next. Here it's the importance of participation of clinical engineering departments in planning and execution of construction projects. So we had a teamwork with facilities management department here in our hospital. We participate since the beginning of the project, since the planning and during the execution and implementation of the technology in our hospital. So we can guarantee we have regulatory compliance and user compliance, human factors engineering, technology requirements compliance, and utilities compliance. So with this participation, we can avoid reprocessing costs at the end of the project. Next slide, please. So to accomplish all of these goals and all of these examples I have done to you, it is important to have many leadership principles. Here we have 3 examples of leadership principles we have implemented here. So communication and teamwork with technology users, it's very important because that way we can have a certain communication and know the needs they have. Presence and accompaniment in sanitary services to identify and propose solutions. It's important for us to be hands-on engineers and participate and to be in the services and from the perspective of engineering propose solutions and new ways to do our work. And then the creativity and innovation culture. It's very important because it led us to be looking for better ways to do our work. So to finish my presentation, it is important for me to share with you some preparation activities our institution have done to face the COVID-19 pandemic as a high complexity institution. So as clinical engineering department, we have participated in the definition with facilities management equipment of possible expansion areas in our hospital, definition of technology needs for ICU and general ward in the expansion areas, definition of needs for that expansion areas based on the inventory we have now and what kind of equipment we can or we have to buy. Technology evaluation, incorporation, and user training, technology movements of during or through the whole institution to best resolve the problems and to best put technology in expansion areas, new services opening, evaluation of masks and ongoing decontamination processes in case of problems to purchase these EPP, help physicians and nurses to implement new ways to save care of patients. And the last of it is help government to know resources available in the institutions in the country to determine the best way to treat patients. That's my presentation. Thank you so much for your attention.
Thank you very much, Paula, for the excellent presentation. Very much appreciated. And next, we'll go to Kim Greenwood in Canada and ask for your comments. Thank you.
As mentioned, can you hear me?
Yes, we can now.
Okay. Greetings, everyone. My name is Kim Greenwood. I am the Director of Clinical Engineering at the Children's Hospital of Eastern Ontario in Ottawa, Ontario, Canada. A medium-sized acute care children's hospital. Next. Back when I started here in the late 90s, myself and my team identified some problems with our operation and limiting factors. In the late 90s, we were 5 staff with no clinical engineers and the department head. We were responsible for maintaining equipment at the Children's Hospital and 5 other smaller community hospitals. At that time, we had no input into medical equipment acquisition, and we only provided limited support to high-end technology such as medical imaging or laboratories. And coupled with this, in Canada, we have a huge geographic area with very few population areas with sufficient density to justify a fully comprehensive service that you would normally see at a larger acute care teaching facility, particularly in the US. That's our closest comparator. We had the desire to grow and develop our team and to achieve a vision of a fully comprehensive service from a starting point of being a modest-sized acute care teaching facility. Next. The only viable route that would allow our team to change this goal is we developed a vision that we wanted to become a fully comprehensive service, typically found in your large teaching facilities. The only way for us to do this was to generate revenue from external sources, as much as we'd already done on a much smaller scale with a few community hospitals. Over time, clinical engineering services were marketed from CHEO throughout the eastern region, resulting in healthcare facilities opting into our 14 hospitals, additional hospitals opting into our service, which created revenue generation opportunities. Offering the regional services was a win-win situation for smaller hospitals. They didn't need to manage a 1 or 2 person department and have that liability, or to manage a large number of service contracts or providers. The service was offered at competitive rates, charging more than an in-house person, but substantially less than original equipment manufacturer contract pricing. Revenue generation enabled us to invest in additional staff and equipment and training as well to expand the service offering to all of our clinical partners. Next. From the vision, we developed a long-range plan for improvement. We developed a multi-year two-pronged plan that included technology and planning and acquisition, as well as expanding the technical support capabilities in all of the clinical environments at Shield, and then gradually we rolled them out to the other hospitals in the Eastern Ontario region. We started out modestly with reasonable, achievable annual goals, and monitored and adopted new industry best practices as they emerged. When redevelopment projects occurred at our hospital and other hospitals, which required a large volume of equipment purchases and service expansion, we took advantage of this opportunity to add both engineering and technology staff. And to not lose sight on what we were doing, we updated our annual goals, keeping it in line with the long-range plan. We built on our successes patiently over 2 decades, and we never lost focus on one important thing, which was the importance of customer service. Keeping in mind that all of these hospitals participating were doing it on a voluntary basis. Next. We worked gradually over multiple years, over a number of years, implementing our improvement plan. We added specialist teams for imaging, anesthesia, allied health, and laboratory services, and grew these teams over time. We gradually added expansion of service offerings as systems were replaced. This enabled us to establish and develop a technology planning and acquisition service. From that, we developed long-range planning tools and redesigned our process over the next few years with very tangible results. Key to this was the redesigning the capital equipment request process in the hospital and prioritizing requests against several criteria, adding objectivity and impartiality to the entire process. And we developed long-range planning tools, which were used to determine the theoretical annual replacement requirements over a several-year period. Next slide, please. The achieved results. The revenue generation enabled investment in our staff and equipment to expand our service offering to our clinical partners in the region. Over the 2-decade period, we transformed our departments being rolled from a technical service group, a very good technical service group, to something broader, which was a corporate healthcare technology management service. We now provide service at 20 hospitals at 30 sites in a catchment area of about over 19,000 square kilometers. With a comprehensive role in healthcare technology decision-making process, we are better able to impact healthcare technology management, both at Shield and throughout our region. Our team has now grown from its humble beginnings to a staffing complement of 6 clinical engineers, including the director, 28 biomedical engineering technologists, and as well as 2 technical team managers. Clinical engineering also stands in a very good position to negotiate new training programs at the same time with equipment purchases, which we couldn't have done earlier on when we first started. Next. This map is just representative of that 19,000 square kilometer area, and it shows you the facilities that we support in the Eastern Ontario region, 20 entities at 30 sites. And one always has to keep in mind, we're working in a public system, but each one of these hospitals are independent and they can make their own decision. They could leave our service if our service was lacking at any time and choose to go in-house or to use a third party. Next. Collateral benefits of establishing this service. Clinical engineering has now been able to offer professional support and specialized training specialized technical support for medical imaging, anesthesia, and laboratories throughout the region. All of these medium to small healthcare facilities in the region now benefit from this resource, normally only found at an acute care, a larger acute care facility. Other collateral benefits, including support mechanisms to two local university biomedical engineering programs. And we also, our presence along with a few of our colleagues also helped with the establishment of a local graduate CE program, and we've been important in a number of academic research projects affiliated with both universities as well. We've also been able to establish outreach initiatives in the last several years to the developing world and provide equipment and technical support to healthcare in 12 other countries to date. And our department has been recognized both locally, nationally, and internationally for our published work and our achievements. Next. Examples of applied leadership skills that apply to this case study. First of all, innovation. We curbed healthcare technology costs in the Eastern Ontario region while providing increased uptimes and improving support to patient care. We transformed the department's role from a technical service group to a corporate healthcare technology management service. As well, another example is teamwork and goals driven. The technical staff gradually expanded their skills to include medical imaging, laboratory, anesthesia, dialysis, and device development. And the expansion of the regional technical service model has was done in parallel with the addition of clinical engineering staff. Adaptive decision making. Our program saw steady growth both in our customer base and a tenfold increase in revenue. The revenue generation enabled investment in staff and equipment to the group to expand our service offering to our clinical partners, both at our hospital and in our region. Thank you.
Thank you very much. Thank you. Now we're gonna listen to Paulo, to Murillo. Murillo Conto, he works in Brazil since 2008. He has experience with the Pan-American Health Organization. He works with Boston Scientific, and he worked with the Ministries of Health, and he has expertise on the national level. He's gonna present his look at the cost effectiveness from national perspective. Please, Murillo, the floor is yours.
Thank you, Riyad. It's a pleasure to can share with you some experience during my time in Ministry of Health and the PAHO WHO office here in Brazil. To start, I think it's important to say that the Ministry of Health here, to understand the process of the investment in medical equipment here, the Ministry of Health here meaningful financial research to the state for medical equipment purchase. Actually, any kind of institutions like it, linked with the public health system can request this research to buy medical equipment in local purchases. To receive the research, the institutions have to present an investment project with basically nomenclature of the equipment, quantity, and technical specifications of the medical equipment required. In the beginning, the scenario that we find in Ministry of Health was a lack of standard list of the financeable equipment, lack of standard nomenclatures, no limit of value or price of the equipment requested, possibility to request equipment not approved by CONITEC. CONITEC is our national commission to new adoption, new technology adoption in the public health system. In other words, it was possible to request some technology not cost effective. The analysis specification the projects to identify the correct institution. And this was a very slow process for approval. And when we started the work there, we only approved it around 1,200 projects. Next, please. Yeah, and what we did, basically we created a national list of medical equipment for the public health system by the minister ordinance. And with the same ordinance, we create a system called SIGEM to organize the equipment from the national list, RNN. And that system, SIGEM, consists basically in the 5 main models. One model to organize the structure of the health service, the healthcare facilities and their ambience. An internal model with a research tool to recover the historical of investments. This is a very important tool because nowadays this tool allowed the Ministry of Health to be able to identify how many ventilators, for example, we have spread all over the country, identify exactly the quantity and the address of the healthcare facilities that 3, an interface web for technical and economic information, consultation from the external public, a tool for multiple choice configuration with limit of prices and some suggested specification with a pre-approved price. And the last one, the bench of prices and technical information got by a program that we created called PROCOT, in cooperation with the industries, in the national and international industries, to get the technical and economic information. Next, please. Here, just to illustrate that 5 tools, this one is the distribution of equipment according to the complexity level of the services and type of application. For every kind of healthcare facility, we can see here in the column of the left one example of the high complexity service, and we have only medical equipment appropriated for this kind of service. And the right side, we have an example for a primary care unit with only basic equipment with low complexity, for example, with manometer, stethoscope, and other basic equipment. This is to avoid that some institutions or healthcare services with low complexity ask some technology, like, for example, CTs or magnetic resonance scanner. The next one. Yeah, this is the picture about the PROCOT, the bench of price and technical information, with the bench of quotation, brochures, a list of vendors and suppliers, and all this kind of information sorted by year. Is a very important to consult the price and the historic of price year by year. Next, please. Some examples of that kind of information about price and technical information got by the cooperation program and PROCOT. Next one, please. This is the example of the multiple choice tool with configuration price limit. We got an automated analysis with this tool in the technical specification for many equipment. This is an example for a vital signs monitor. And with this tool, we can promote over than 700 combinations, different combinations. In the right side, we have the features like, for example, battery life, size and type of screen, types of the vital parameters that the monitor must have. And the right side, we have the options And with each option, we have a value to add in the final price. Next one. This is the example of the web interface for the external public consultation, consultation about the technical specification, prices, vendors, and very important to support the managers, the health managers in the states and the city and the hospital spread in all over country. The next. Yeah, our main results with this initiative, the quality of projects got a meaningful improvement. After we finished the whole implementation, the investment projects approved, it was almost 4 times higher than the previous year, with some number of the analysts. And that time we had 10 members in the team among clinical engineers, health technologists, and nurses. And the financial resources were invested with more efficiency in this case. We can multiply twice the amount of investments in medical equipment in our country. Next, please. Yeah, this is the experience in the international organization at PAHO and WHO Brazilian office. Basically, the PAHO works in cooperation with the local governments. In our case, our main cooperation with Ministry of Health and our regulatory agency, the Anvisa. And our roles basically, it was the adoption, to support the adoption of new technology into public health systems, support the National Commission for New Incorporation, new adoption of technologies, basically preparing reports with scientific evidences based in HTA practices, and of course with cost effectiveness and budget impact analysis. Also, we work with capacity building in HTA and HTM, especially in medical device, because it's very different to make to evaluate medical device and medicines, including, of course, issues about clinical engineering. We promote a lot of workshops and courses in partnership between Ministry of Health and the WHO collaboration centers, like, for example, the Universidade de Santa Catarina with the Professor Renato Garcia here in Brazil, and also the University of Vermont with Mr. Toby Clark, a very good partner of the PAHO for our Americas region and Caribbean, to support in this kind of activity and capacity building. Also, we developed some guidelines and other publications in HTA, some report, for example, based in evidence-based. And 3, we had a lot of participation, national, international networking groups. For example, we organize a lot of meetings and webinars with partners in partnership with the HEBRATS. HEBRATS is the HTA Brazilian network, and REDATSA, the HTA Americas network. And we have a very meaningful achievement in São Paulo, in Brazil, 2017, when we organized the first Latin American and Caribbean Summit on Clinical Engineering in Health Technology Management, in partnership with IFMBE and the American College of Clinical Engineer, as a pre-conference of the second International Clinical Engineer and HTM conference here in Brazil. Next, please. This is some examples of our activity in PAHO, the meeting, the LA summit, and the guideline about how to evaluate medical equipment in the HA principles, and also the report about the robotic surgical device, the Da Vinci Robo, for surgical practice that we prepared to support the decision make of the CONITEC in Brazil. Next. In conclusion, and Tom asked me only 3 leadership skills learned, but I put a little more. Basically, I think we have to have the winning spirit to demonstrate the goals worth, keep the focus, hard work, and to believe in our projects. And the participative leadership, share your ideas with the team and stimulate the suggestions and improvements. Call the team to be part of the project, to exercise the capacity to listen and open mind for new ideas, and open mind to listen to some criticism also. And the capacity to organize efforts and synergy, basically identify talents, in other words, right people to the right task, and promote the collection and registration data. It's very important. If you didn't write and you didn't register, you didn't make it. And be part of the decision-making process with data. I think we have to get used to having data as our best friend. Never go to the meeting, a decision-making meeting, without data. I think this is my message. Thank you very much for the opportunity and your attention.
Thank you all for hitting your timelines beautifully. Riyad, the floor is yours for questions.
Thank you, Elliot. Thank you, Murillo. We have a couple of questions, nice questions coming in. Well, one question related to the shortages of PPE. How do you think, based on your experience, do you reprocess these PPEs? Because everybody now, during this COVID-19, all countries, they have shortages with the PPEs. So the first question, do you reprocess them? And there is a request that the clinical engineers, they need to acquire knowledge of basic sterilization. So these 2 questions related to sterilization and reprocess. The questions for you, Kim and Murillo and Paula. Who likes to answer, please?
I can answer from our perspective. So for the first question, I want to say that in our hospital, we are doing a comprehensive evaluation of all of the information we have now for decontamination processes and recommendations for EPP decontamination processes in case of shortage. So we are studying the papers from FDA, from manufacturers of masks, gowns, and equipment. We are studying the information from CDC, from FDA, and from NIH. So we started some tests with our sterilization processes people, and then we're going to do some tests with or in the EPPs we have decontaminate, and with all that information, papers and tests we have done, we are going to decide if our hospital is going to do the reuse of that EPPs in case of shortage. So we're studying all the information possible. In this moment, we don't have a shortage here in Colombia or in the hospital, so we are preparing for that moment that way. That's my answer.
Okay.
I think it's in a regular situation, it's not recommended to reprocess PPE, of course. But I think we are living a war situation, a war state of situation. So I think in the last case, if you can find some kind of a way to validate the process with to make sure the minimal of safety of the process, I think it's possible. But it's very difficult to make some kind of recommendation about that.
Kim, any notes on that question? You have
Kim, you're
to.
muted.
You have to unmute your phone, please, Kim.
Okay, we haven't as of yet experienced shortages with PPE, but what we have done, our research institute has been evaluating reprocessing N95 masks. And they've had a study going on in parallel, and I'm actually waiting for the results of it. This is sort of our backup plan in case we do face shortages down the road. To date, we haven't.
Okay. So another question for you, Kim, from Firdaus. They're asking two questions. How can you manage the BE and the clinical engineers? Do you house them in different sites? I mean, do they reside in different hospitals? And what were the challenges regarding how you manage your resources, your manpower, having different sites, different hospitals?
They do reside at different sites. I think in total, I have people permanently based out of about 6 sites. And in some cases, they cover more than one facility or more than one site. The administration works out of the Children's Hospital, of course, but it allows us, and one central call line allows us to, especially after hours, to dispatch staff depending on requirements. If a call comes in after hours or even during the day, and there isn't trained staff at a specific facility, we will pull someone from another site and send them to that site. We have benchmarks that time standards that there's an expectation we call within 30 minutes, and we respond on site usually within 3 to 4 hours for service.
Okay.
And we're monitored by a central health authority buying group that monitors our performance, and it's pretty transparent. Everybody sees everything up front. And that answers to the second question as well, too, that was there. How do we balance it? It's always tough. We've always got to make sure we have enough adequate people and that the training is dispersed evenly throughout the department, and that we continually work at new training efforts with our staff.
Perfect. So another question from our friend Fred Hosea for the speakers. How do you manage the growing relationship between the IT people and the clinical engineers, especially with the technology assessment, knowing that the medical devices are more and more computer-like equipment? Any answers from the speakers, comments?
Yeah, I have an answer for that. So here in our hospital, we started a team work with IT people. So we created a committee. The committee is CEIT committee. So we have a monthly basis meeting, and that means we discuss the projects we have here in the hospital for the whole year, and the goals we have accomplished together, and what kind of participation we need for the next projects. And we have, for example, the participation, as I said in my presentation, of IT people during the technical specifications review and demonstration of technology. So when that technology is based on computer or it has a lot of information systems, they give us an input about costs and needs to implement, or to best way to implement the technology. That's why, that's how we are doing that part in our hospital.
Great, thank you. Another question? Yes?
Just a comment about the TIT team, IT team in Brazil. When we work at the Ministry of Health, we work very close to the IT team, including to develop the system, the information system, but also to support the analysis of the features of the equipment involving IT issues.
Okay, great. Another question related to how to optimize various PCR testing platforms. Any one of you has any experience on that level?
In our hospital, we are trying to license our molecular biology lab to do PCR testing for COVID here in Colombia. So we have just one PCR platform, but we are optimizing the use of equipments, for example, a centrifuge equipment before the PCR usage. So we move many equipment to that lab. So it led us to have a lot of tests done and to better use the whole capacity of the equipment. So we, for example, just had a centrifuge of a few tests. For example, we have a centrifuge for just 10 spaces, but we put many, so we can have the 96 spaces we have in the PCR system to do the whole activity in just one way. So that's the way we are optimizing the lab and the PCR testing platform.
Thank you, Paula. How do you relate or define the return on investment, the ROI? Is it only on dollar value, on profit, or ignoring the clinical and patient benefits? Any comments on that?
The point is that perhaps at some point, our field perhaps needs to develop metrics that allow us to participate in the outcomes decision, because many countries are moving towards outcome-based evaluations of hospitals and clinicians. And we have done a good job, I can see from your presentations, in the fiscal or financial management of clinical engineering related services, health technology assessment and the like. I believe we're going to see more questions moving into the outcome side, and perhaps an open-ended discussion for our community in the months and years ahead. And we have 2 more minutes left, so Riyad, perhaps you can choose one more question to ask from our stream of questions.
Yes, we still have 3 questions, 3 nice questions, but obviously that all the audience are very much interested to learn from the speakers, their expertise in facing the COVID-19. One question says, what's the involvement of the clinical engineers in medical devices disinfection and their responsibilities, and whether we can 3D print the N95 masks? Can anyone ask in less than a minute, please?
We haven't 3D printed N95 mask, but what we have done is 3D printed and manufactured face shields. Actually, it was another initiative led by our research institute and got community involvement in the Ottawa area. And it's worked out quite well, actually. We have more supply than we need.
Okay, and what about the involvement and the responsibilities of the clinical engineer in medical devices disinfection?
That is something that's done typically through our medical device processing group. And they're the professional group that monitors that. We should, as clinical engineers, have a good understanding of sterilization techniques. At least I believe so.
Yeah, we understand that all the medical devices come with manuals, and they have all the information from the manufacturer. What are the proper disinfection protocols that need to be done? And normally we train the end users on the proper disinfection. So training on proper handling and disinfection is done definitely by the clinical engineers. So maybe the responsibilities. Yes.
We organize the training with the vendors when we buy new systems.
So
Absolutely.
I'm afraid we have reached the top of the hour, and we need to thank Kim and Murilo and Paula for this excellent presentation. Riyadh, thank you for your co-hosting and moderating of this session. And thank you for IFMBE for the opportunity to present these perspectives and continue in the dialogue and growth of our profession.
Thank you.
Thank you.
Thank you,
for the
Elliot.
opportunity.
Thank you,
Be
Riyadh.
safe, everybody.
Thank
was
you
a
very
pleasure.
much. Thank you, Maria.
Bye.
Bye.
Bye-bye.
Bye.